everyone. This is the National Hispanic Medical Association's Congressional Briefing. We do one or possibly two briefings a year to focus in on policies that Congress is debating that impact the Hispanic community as well as other underserved communities. I'm Dr. Elena Rios, President and CEO of the NHMA, and we have a great lineup of speakers today. I just wanted to find out if the Congressman is on his way.
Yes, Congressman Raul Ruiz is on the call.
Okay, so let me introduce Congressman Ruiz. Congressman Ruiz is from the 36th District of California, which includes the Coachella Valley, as well as a lot of cities, Banning, Beaumont, Blythe, Hemet, San Jacinto. The Congressman is a doctor who's been, has had many, I'm going to say many careers, not only in emergency medicine, but academic medicine, and has multiple degrees from Harvard. And I just want to say that he grew up in this community and is a champion for his constituents. And we've known each other for quite a while since we were both at UCLA at the same time. I'm a little older than the Congressman. I was a medical student when he was a pre-med. And Raul, we're very, very, very proud of all of your work. And you're here to tell us today a little bit about lessons learned from COVID-19 for us to take away and to think about policies that we can advocate for as the National Hispanic Medical Association. And especially for those patients with asthma, we thought we'd use an example of patients that have respiratory problems who really needed extra help with COVID-19. Congressman? Maybe he's not there. Let's see, who told me he was here? Okay.
Oh, there it is. Okay.
There you
Sorry,
are.
guys. There I am.
Okay.
I was on mute. Somehow I got on mute. But hello,
That's okay.
everybody. My name is Congressman Dr. Raul Ruiz. I'm an emergency medicine physician, and I represent California's 36th Congressional District. I'm also chair of the Congressional Hispanic Caucus, and it is a pleasure to join the National Hispanic Medical Association for today's Congressional Briefing. I have a very special history with Dr. Rios. When she said I grew up in my district, I also grew up in the National Hispanic Medical Association. Elena Rios was the person that I sat with when I was an undergrad, when I didn't know any medical students or public health people or very many doctors. And I asked her about how it was to be a doctor. So she provided some mentoring when I was, I believe, like a sophomore at UCLA undergrad. And then I went to NHMA conferences as a medical student at Harvard. And then now I've been presenting and attending and moving our legislation forward as a member of Congress. So growing up with farm workers in the Coachella Valley, my parents are farm workers, I saw the challenges and barriers to healthcare that my family members, my neighbors, and my community faced. The same community that taught me so much about resiliency, hard work, and taking care of one another. These experiences help shape the way I approach my work in Congress. They illustrate for me the urgency of addressing the health challenges our communities face. We are now well over 2 years into this public health crisis. Can you believe it? 2 years. These 2 years have shined a light on the disparities that communities of color face when it comes to accessing healthcare. One of the disparities we've seen is that Hispanics, African Americans, Native Americans, and high-risk essential workers carrying a disproportionate burden of infections, hospitalizations, and deaths from COVID-19. And yet, despite serving on the front lines of this pandemic as essential workers, those same communities faced barriers when it came to testing, vaccines, and treatment. We all knew this. Those of us that work on disparities and health inequities for many years, we knew that it existed and that the pandemic would only exacerbate it, and it did. I saw it firsthand when I went out into farm worker communities in my district to administer COVID-19 tests and vaccines. The fact is, we cannot continue to rely on a healthcare delivery system that is fraught with disparities. In order to fix these disparities, we must learn hard lessons from this pandemic, work to fix the system and improve health outcomes. A key part of this work is forming strong public-private partnerships that work together to achieve health equity. The Biden-Harris Federal Retail Pharmacy Program, for example, has been a success in my district with over 40% of vaccines offered in stores and in counties with high social vulnerability index scores. But it's not just about making the vaccine available in these pharmacies, retail pharmacies throughout our country, also in underserved areas. It's about taking the vaccine into the community. We've seen, for example, affluent families who had time to work from home with high-speed internet, gamed the system, had the literacy to learn how to get their vaccines, even if it meant traveling to the underserved communities and get vaccinated in underserved communities when their local pharmacies were inundated or didn't have enough vaccines. So we can't just rely on that either. And that's why it was so important that the retail pharmacies partnered with community organizations, FQHCs, and take the vaccines into the workplace, into the churches, the places of worship, into the school systems, and inoculate the hardest to reach members of our communities. So we must also reevaluate our education and training procedures to create pipelines that will rapidly increase the number of providers in vulnerable communities. So creating pipelines with pre-med students and residency programs in underserved counties, like I did at the University of California, Riverside School of Medicine. I was a senior associate dean of community engagement and partnerships. And before that, I had created a pipeline mentorship program called Future Physician Leaders, mostly kids from underserved communities who wanted to go back and serve in their underserved community. And so it became a pipeline through undergrad, medical school, residency, and into residency programs that I helped initiate into those underserved communities through FQACs and others as well. And as healthcare delivery continues to move more toward home-based care and community-based care, we must better utilize public health nurses, community health workers, or promotoras for underserved communities who are on the ground, who understand our communities, who speak our language, who understand the barriers to healthcare, and who can provide them with culturally sensitive care. So these steps will help us achieve a healthier future for all. So members of the Congressional Hispanic Caucus understand the gravity of addressing the many disparities caused by the COVID-19 pandemic, especially as we continue to learn more about this virus's long-term effects. And I'm proud to lead this hardworking, dedicated 36-member caucus that has introduced legislation to help improve health outcomes for communities across the country. Bills like the Mental Health for Latinos Act, introduced by longtime mental health champion and leader in Congress, Representative Grace Napolitano, that bill would address the impact of the COVID-19 pandemic on the mental and behavioral health of Hispanic populations. The Senior Act, introduced by CAC member Rep. Lori Trahan, would help assisted living facilities keep their doors open and would expand the caregiving workforce for the millions of the seniors that rely on the critical, affordable care at assisted living communities. Additionally, the COVID-19 Health Disparities Action Act, introduced by Representative Tony Cardenas, would promote vaccination among racial and ethnic minority groups and other populations that have experienced health disparities related to the disease. Look, the list goes on, and I have several bills, but as chair, I focus on my members' bills when we have these conversations. But at the CHC, we will continue pushing for greater health equity to address the impact of the pandemic on Hispanic communities across the country. Equity cannot be a reaction or an afterthought. equity must be the prelude to any bill or law that is passed. Equity doesn't spontaneously happen. You need sweat and muscle to move equity. It is a verb, an action. We need to design our bills with equity in mind. We have to put the extra effort and resource to achieve equity in our healthcare delivery system. And that means work. And that means somebody who's always going to be at the table to ensure that there is an equity design beforehand. We must break the cycle that we have been living for so many generations of large healthcare bills being moved through, and then we react after the fact when we start to see that the resources don't go into our community, when we start to see the health effects of those that have been left behind, and we start to see the expansion of the health disparities between our communities, and then we complain or we react and we protest, and then we try to fix it after the fact. So in this case, with this administration, there's the Justice 40 initiative designed into the American Rescue Plan, for example, that made sure that the 40% of the vaccines, 40% of the resources go into highly affected, underserved, high disparity communities. This time around, we made sure that there was a strong partnership through community health workers, or FQHCs, to ensure that the vaccines got into the arms of our hardest to reach community members. And it worked. You see the vaccination rates being the gap between white and Hispanic vaccination rates have dramatically decreased. So equity, when done right, as part of the design of a bill with the active implementation, can help alleviate disparities, not just in vaccination rate, not just in testing, but this can also include making sure that we have the right education in our communities about asthma care, to make sure that our kids have the appropriate regimen of asthma, to make sure that we have asthma or respiratory or people competent in treating asthma in underserved communities, that we can employ community health workers to go into our homes, into our communities, to assess the environment for allergens, to assess the environment if anybody is smoking, to get them into a smoking cessation program, to make sure that they have all the wraparound services and counseling necessary to make sure that our children do not suffer from the disproportionately high asthma rates in our community. So we need your voices, your expertise, and your firsthand accounts to advocate for health equity in your communities. Thank you for your hard work and for hosting today's important briefing. And together we can work towards building a country where your background, your zip code, and your income do not determine your access to quality, affordable care.
Thank you, Congressman Ruiz. We appreciate your time. I know you're busy, and we look forward to following up with you on how we come up with some policies for you this year to continue your great leadership.
Thank you. I serve on the Health Subcommittee of Energy and Commerce, and I'll be like a dog on a bone, a bulldog on bone. I'll never let go until we achieve it. So yeah, looking forward to working with you. Okay, thank you. Thank you. All right. Bye-bye. I'm going to go now to our slides from the beginning of the session. We have a housekeeping slide just to let everyone know that's joining us today to please keep all your microphones muted. And we would like questions in the Q&A box for our panelists. The recording of this webinar is housed on the nhmamd.org website and our YouTube channel. And that recording and slides will be sent out in about a week to everyone that registered for the event. And we again thank you for this, for your participation. Next slide. The next slide. Yes. So I have a few comments of policies just to set the stage here. Can I go to the next slide, please? And I'm not going to read all of these, but I just want to let you know that Congress, as Congressman Raul Ruiz mentioned, has been very busy on looking at ways
to help our communities, given that COVID-19 is here and is not going away anytime soon. And what's happening is there are comprehensive laws being done to look at how to take care of, especially patients with long COVID. And this is just an example. There are different agencies that get funded by Congress. For example, the Agency for Healthcare Research and Quality has a patient-centered outcomes research trust fund. And this bill would like to support a registry to collect information on how people have been dealing with long COVID. HHS, the Department of Health and Human Services, would also conduct or support research and develop resources for other post-viral illnesses that will happen, that we now know that there will be more epidemics and pandemics that will affect our people, and especially those rights of people associated with their employment, their disability status, and their education. CDC is another agency that should disseminate information and have more community-based health communication campaigns for people to know about vaccines, for example. The Centers for Medicare and Medicaid must expand its own data warehouse for chronic conditions to collect data on services and items through Medicaid and CHIP. And then there's an administration for community living that can award grants and contracts to states, but also to healthcare providers, to hospitals, and to legal services, especially. Next slide. This bill is another bill that says the HHS should award competitive grants to create and expand clinics, the community health centers that we have in our communities to treat patients, and also spells out that it's not just urban clinics, but it's rural clinics and urban Indian health centers and state and local health departments that also have their own clinics. Next slide. Another example of how policy helps us is to have CDC be awarded different types of grants, again, for community health centers, but also for organizations that are not community health centers who can have education programs, for example, to prevent and to treat and to raise awareness of conditions such as asthma or cancer that increase the risk of mortality from COVID-19. And let me just tell you, that's why we had this meeting today, because we wanted to focus on some of the patients that are the most vulnerable and the lessons learned from the most vulnerable, especially those patients with severe asthma. So let me go to introduce the panel. I'm not going to go over the rest of these slides. They're just a few examples of policies that are happening right now. This one, well, let me just say that there is a Health Disparities Action Act to promote CDC grants, but instead of just grants for public health surveillance and data collection, it's really to increase public awareness and to have campaigns for the most vulnerable that we call health disparity populations. So let's go to the keep going. Allergy and Asthma Day, that was just another example of policies that we're going to hear from our panelists right now. And to kick us off with the focus more on the lessons learned about COVID and asthma is Dr. Vivian Hernandez-Trujillo, who's a clinical professor of pediatrics and division director of Allergy Immunology at the Herbert Wertham School of Medicine, Florida International University. Dr. Hernandez.
Thank you so much. Thank you, first of all, for the opportunity to be here. This is actually a disease that I'm very passionate about. As you know, I'm a Latina, but I have also had asthma since I was very young, and I'm a mom of a daughter with asthma. So this is near and dear to my heart, not only professionally, but personally as well. Next slide. We're basically just going to talk briefly about asthma. We'll discuss a little bit about severe asthma, and then I'm going to focus more about asthma in Latinos. So asthma is a chronic disease. It causes inflammation or swelling, and then bronchoconstriction or narrowing, and you can see it here on this picture. And the result is either coughing, shortness of breath, wheezing or difficulty breathing. And one question that I hear often is, I've never wheezed, so I can't have asthma. And actually, there are different forms of asthma, and asthma presents differently. You may be an asthmatic that just presents with cough and shortness of breath. So really, as every disease is a spectrum, asthma is a spectrum as well. I think the main idea from this slide is that patients truly can live a normal life if there's adequate asthma control and if it's maintained. And I think that's something we all need to keep in mind. And going back to what we heard about the disparities, everyone really needs to have access to the medical care to achieve this goal. Next slide. The triggers is the next thing I want to focus on, because when we talk about social determinants of health, there are many things that can be addressed. So first and foremost, respiratory infections are the main trigger, especially in young children, but in anyone. So respiratory infections of any type can be a trigger. But where we can make an impact, especially as a pediatric allergist immunologist, is identifying some of those environmental allergens. So it may be dust mite, cockroach, mold, pet dander. There's a whole variety of different allergens that can trigger asthma in different patients. So recognizing them, diagnosing them, and then trying to address them are very important. Other causes and other triggers include smoke, sudden temperature changes in many patients, strong emotions. So someone that hears very bad news and starts crying suddenly, or hears a really great joke and starts laughing very aggressively, these can all lead to an asthma exacerbation or attack. And then intense exercise in some patients. So the goal is always to maintain control so that the patient can lead a normal life and engage in whatever activity they would like to. Next slide. Another question I'm often asked is, can asthma be cured? Asthma is a chronic, lifelong condition. While it cannot be cured, it can be well controlled. And with proper treatment, it often does improve over time, but proper treatment includes taking medications, following up with your medical team, avoiding those triggers. So that's really, again, the take-home message on this particular slide. Next slide. This slide actually makes me smile as an asthmatic patient and as a mom of a child with asthma, because when I was diagnosed and when I started with problems many, many years ago as an infant, the reality is that we had one medication or two medications, and they had a lot of side effects. It was oral steroids and a lot of side effects, a lot of long-term side effects. Now I look at this and I see different types of inhalers, different types of medications that can appropriately address different types of asthma. And honestly, I'm thankful that there has been an interest in asthma research, because this really has helped the control of all of our patients with asthma. So beta agonists are what we call our rescue or quick relief medications that really are to be used only as needed. Inhaled corticosteroids is what maintains or controls our medication or our disease over time. So these are medications that need to be used more regularly, and they help maintain that control of our symptoms and our disease. And then biologics are really the newer medications. They're different injectables that we can use to really target different types of cells that can become a very big problem, especially for patients that may have allergic asthma. So this, the respiratory treatment slide continues to increase the number of medications, and that is something that's very, very good news. And another reason why we need to address the groups that really don't have access to these particular medications, because it can make a very big difference in your quality of life and in your health. Next slide. Why is asthma as a disease important overall? Well, 25 million Americans are diagnosed with asthma, 1 in 10 children, and over $80 billion of annual costs. As an allergist immunologist, the one that hurts me the most is the over 3,000 deaths per year. And really, this to me is something that needs to be addressed. Again, We've seen the disparities in healthcare over the last several years highlighted more than ever, and we need to address this because these are preventable. 13.8 million missed school days. Again, as a pediatric subspecialist, this is also very important. We need to address this because children missing school is something that needs to be important to each one of us. And 14.2 million missed work days in adults. 3 in 5 patients feel they need to limit their physical activity. 71% misuse of their inhalers, which again is concerning. And then 1 in 5 patients cannot afford medications. All areas that should be addressed. Next slide. I'm going to focus a little bit now more on pediatric asthma. It's one of the more common chronic conditions affecting over 7 million children in the US. And severe pediatric asthma is not only difficult to manage, but it utilizes a large part of the resources available for the treatment of patients with asthma. So we need to identify these patients and treat them so that, again, they can lead a normal life. A true need exists here to improve the treatment of our patients with severe asthma in order to keep them out of the emergency rooms and out of the hospitals and prevent those deaths. Next slide. When we talk a little bit about asthma prevalence in Hispanics or Latinos, in 2018, 2.3 million Hispanics reported a diagnosis of asthma. The prevalence of asthma is 100% higher in our community as compared to Caucasians. And in the Latino community among adults, 6.4% of asthma rates are seen among Hispanics. And out of that particular group, 15% are from Puerto Rico and 5% from Mexico as a country of origin. The prevalence rates are increasing, in particular in these underserved areas or in patients with difficulty accessing medical resources. Next slide. I like this slide in particular because it actually shows state by state. This is actually a handout from the CDC that shows the prevalence of persistent asthma in children, and it varies in state by state. In Oregon, for example, it's 45% and up to almost 75% of children have persistent asthma in Mississippi, and that is an area of concern. Patients with persistent asthma are the patients that require the long-term medications in order to control their asthma symptoms. And almost 60% of patients with the current diagnosis of asthma do have that persistent asthma. What does that mean? That means they're either controlled using long-term medications, or they're poorly controlled either due to the lack of response to medications, or they don't have medications either available or they're not using the medications that are available. So severity is something, again, that we need to consider because that the more severe, the more at risk. And you'll hear in the next talk about risks associated with many things, but including COVID-19. Next slide. Among children now under 18, 8% of all Hispanics are affected by asthma. And again, out of this group, 17% from Puerto Rico and 7% from Mexico as a country of origin. The asthma cases in Puerto Rico represent twice as many asthma cases compared to other Hispanics. And children of Puerto Rican origin suffer from asthma 3 times more than white children of non-Hispanic origin, which is something that, again, highlights the need to be addressed. Next slide. The one thing I want to point out in this table is that overall, amongst the diagnosis current asthma in children under the age of 18, overall in the population it's 7.5% and 7.5%, and then you can see just under it, this was from 2018, 8% of Hispanic children. Next slide. So when we talk a little bit about the disparities that we see, and they can really be described in many different areas, but Latinos who preferred to communicate in Spanish receive fewer asthma diagnoses in different settings, including community health centers in the US, compared to Latino patients who preferred to communicate in English. This is something near and dear to all of our hearts. This needs to be addressed. Also, Latinos received a diagnosis of asthma less frequency the first day they presented with the same symptoms compared to their white non-Latino patients. These are different studies that have looked at this. So again, different areas that need to be addressed. And as we talk about the path to achieving health equity, we do need to consider different social determinants of health. And I'm not going to talk a lot about this because it will be addressed somewhat in the next presentation, but certainly having spoken about some of the environmental triggers, speaking of stressors, these all do impact our patients with asthma and their overall health. Next slide. Again, different studies have looked at different triggers. Respiratory infections during the first 2 years of life does increase the risk of developing asthma in Puerto Rican patients. In the National Health Survey of Children, they did notice there were more visits to the emergency room among asthma patients from Puerto Rico and Mexico. And then emergency room visits and hospitalizations related to asthma in Latinos was double those in Caucasians. And another area of concern is that there was an 50% increase rate of rehospitalization. So even after they received care, they were more likely to have to return for more care. Amongst obese children, the risk of oral steroid use increases by 15%. And as I alluded to before, this can have long-term side effects if used over time. Next slide. As far as the importance of adequate asthma control, studies show that Latino school-age children from Puerto Rico, country of origins of Mexico, and then Central or South America use rescue medications greater than in other groups. And the reason this is of concern is it's telling us that they are not well controlled. So the more, either they're not well controlled or they are using medications that are not sufficient. Mortality from asthma, again, is higher amongst Latinos, especially from the origin of Puerto Rico. And the death rates from asthma in patients from Puerto Rico is 75% to 200% higher than in Caucasians. So again, these disparities need to be addressed. Next slide. This is just a summary slide that a need exists to improve the medical care of our patients with asthma, resources to improve the understanding of disease and improve treatment in our communities, again, is very important. And outreach is needed to improve the outcomes of our patients, improve health equity, and decrease those disparities that disproportionately affect our communities. Thank you so much for your attention.
Thank you, Dr. Hernandez. That was great and a great overview, as well as some ideas for thinking about how to improve severe asthma, especially in our communities. Now to continue, Dr. Purvi Parikh is going to tell us more about her lessons learned from COVID-19 and asthma policies. She is an allergist and immunologist at the Allergy and Asthma Associates of Murray Hill in New York. She is currently on faculty as a clinical assistant professor in medicine and pediatrics at NYU School of Medicine. Dr. Parikh?
Thank you. Thank you very much for having me. It's a very important topic. Okay, so with that, we'll move on, and I'm going to underscore a lot of what Dr. Trujillo Hernandez went through, and then just give some of my own experience. I actually worked in 5 of the COVID-19 vaccine trials from day 1, to now, and so health equity was a big priority, especially in these trials, as well as all of our COVID-19 research. Next slide. So, we all know that patients are in need of health equity. There are major disparities, as the congressman said, us in the healthcare community knew already existed for years or decades before the pandemic, and this just kind of put a bright spotlight on it. So, you know, all patients, what do they need? They need to understand their health and human condition. All patients need to have access to medical care, medications, and ongoing health support. And Hispanic patients especially experience barriers to healthcare, and we need to respond to create health equity for all. And so again, the important things are these conversations need to take place, what we call in medicine, shared decision making. You know, as Dr. Trujillo mentioned, patients are a lot more comfortable speaking in their own language. A lot of their concerns are met, you know, and a lot of cultural barriers exist, you know, in that are blocking access to healthcare or access to equity. So these conversations are really important. And every single patient, despite their background, even 2-3 patients within the same background, all have different needs and fears and concerns that may be blocking them from achieving good asthma control, as we've found. A medical home, so there needs to be kind of that entity where patients have access to care, not only through the emergency department, but also routine care, you know. Frequent visits to the emergency department do not show that someone is well controlled. In fact, it's the opposite. It shows a lack of good asthma control, and that sets them up for a vicious cycle, you know, of increased mortality as well as morbidity. And of course, assistance to navigate the healthcare system. As we know, our healthcare system is very complex. And even as a physician, I find it confusing at times. So I can only imagine how difficult it is for patients to navigate. Next slide. So, you know, as Dr. Hernandez underscored, asthma is a chronic disease. You know, it's one of the most common chronic illnesses, especially in the pediatric population. Emergency care is something that is one of the most common things we provide emergency care for. And the Hispanic and Latinx communities are twice as likely to visit the emergency department for asthma than their Caucasian counterparts. And then children, you know, are 40% more likely to die from asthma if they're from Hispanic and Latinx communities compared to their Caucasian counterparts. So, you know, this is quite a large disparity. So what do? You know, we need to make sure we arm our patients to be proactive with the knowledge and skills that they need to make informed, evidence-based decisions about their health. And they need trusted partners and sources of information to learn how to help themselves and others. And it does appear that poorly controlled asthma is what increases this risk, especially for children and Hispanic populations who tend to have worse asthma control due to their health inequities. And I found this to be the case, especially with the rollout of the COVID-19 vaccine. Rightfully so, there was a lot of skepticism in communities of color because of distrust of the healthcare system, because of a lack of trusted messengers. So these messengers are extremely important. Community-based physicians, nurses, and I have many patients that told me, I don't care what anybody else says, Dr. Parikh, if you tell me to get the COVID-19 vaccine, I will get it. And so that is why that role of conversation between the patient and the trusted messenger, trusted healthcare provider is so crucial and important and can make a world of difference. Not only, of course, in vaccinations, but in asthma control and control of all chronic illnesses. Next slide. So, you know, there's a lot of factors, you know, that play to these increased risks in asthma. So if you look right here on the left side, a lot of the factors, unfortunately, are socioeconomic. So adults with an annual income of less than $75,000 are more likely to have asthma. And then adults who didn't finish high school are also more likely to have asthma. So there is an educational component too. And it does matter, you know, how much. So people with asthma who earn less than $50,000 a year are twice as likely to have an asthma flare. And we know from what we previously mentioned that asthma flares then lead to uncontrolled asthma and the increased risk for bad outcomes from asthma, such as deaths, such as those 3,000 deaths per year that Dr. Trujillo was mentioning. All of these, by the way, are completely preventable. We should be having 0 deaths. So that equates to almost 10 deaths from asthma on a daily basis in this country. So adults who cannot afford their asthma medications is 1 in 4 among the African-American population and 1 in 5 amongst Hispanics. And this is key because these medications are really crucial for keeping that asthma under control and for keeping our patients out of the emergency room and out of life-threatening situations. And then other factors that can lead to asthma disparities, of course, access to care. If you don't have transportation to see your doctor regularly, to get your checkups, to get your breathing tests, if you don't have the transportation or access to get to the pharmacy to pick up your medications, obviously that's a huge problem, and your asthma won't be well controlled. Income, of course, poverty plays a big role into it, but even with health insurance, forget not having health insurance, but even with health insurance, many of these medications cost considerable amounts of money. So that is a huge barrier. And then environmental allergens and irritants. So many people don't realize that asthma is as much an external disease as it is an internal disease. So the most common cause of asthma is allergies. And so if you don't have access to keep your home allergy free, your asthma won't be well controlled. And we can see that difference even within a difference of 20 blocks in New York City, between the Upper East Side and Harlem and the Bronx. Asthma control is significantly worse based on your zip code, and that's all due to environmental reasons. So there are certain areas where there's more cockroaches, more dust mites, more mice, cigarette smoke, and the closer you live to highways, it's been shown to have higher rates of severe asthma and poor asthma control. And of course, education inequality. Just the basic lack of knowledge and understanding of the disease can also lead to problems, such as using asthma inhalers correctly and not following through on treatment. So all of these things are very important, and empowering our patients is the best way we can to help level these inequities. Next slide. So the deep-rooted inequities, asthma care and the COVID-19 pandemic have revealed very deep-rooted inequities, as all of us have been talking about today, especially in communities of color. Hispanic Americans are twice as likely to die from COVID-19 than non-Hispanic whites. And the Hispanic community has the highest rates of COVID-19 hospitalizations. And we see this translated across other communities of color as well, such as Black Americans. And we found even within, New York City, which was the epicenter of the US, Asian Americans and other minorities and people of color. So these inequities, again, we knew existed for a while, but the pandemic has only brought them to the forefront. Next slide. And there's also been studies recently that have shown that children, particularly with poorly controlled asthma, have a higher COVID risk. So a recent study that was a large observational study from the UK showed that children with poorly controlled asthma are 3 to 6 times more likely to be hospitalized with COVID-19 than those without the condition. Experts also advise that the 5 to 17-year-olds with poorly controlled asthma should be considered for vaccination to reduce the risk of infection and the spread of COVID-19 to schools and households. Now, this study came out before we had the approval for younger children. So now we recommend it even in younger individuals who are at risk of developing asthma or who may already carry that diagnosis. Next slide. So people with moderate to severe COVID-19. So the risk of severe illness from COVID-19, people with moderate to severe or uncontrolled asthma are more likely to be hospitalized, not just with COVID-19, but any respiratory virus. That's why we always advocate for vaccinations, not just for COVID, but even prior to the pandemic, we made sure that our asthmatics got their flu shots, their pneumonia shots, and were as protected as could be against all respiratory illnesses. And there was a lot of misconception early on during the vaccine rollout and confusion that people with allergies and asthma couldn't get the vaccine, that it was dangerous, but this is actually not the case. not only is it not dangerous, actually it's recommended, because not having the vaccine is far more dangerous in this population. Again, follow CDC recommendations for cleaning, hand hygiene. You know, unfortunately, COVID is still around, and I can tell you, I'm diagnosing cases on a daily basis. So it is very much there, even if people are sick of the pandemic. Coping with stress and anxiety is very important, because those things can actually worsen your asthma control. Follow your asthma action plan. So every asthmatic should have an asthma action plan on what to do on good days, and also days when their asthma starts getting out of control. So that way they can get ahead of it before it turns into a very severe asthma attack or a hospitalization. And of course, as we mentioned, take those steps to protect yourself from COVID-19, hand washing, masking, distancing. This will go a long way, even with flu and other respiratory viruses and bacterial infections. Next slide. So then just, a few more notes. One, people have a lot of fear and misconceptions about asthma, tend to be fearful with worse outcomes with COVID-19. But again, the evidence shows that if your asthma is well controlled, we were pleasantly surprised. The outcomes were not severely worse, but those who were uncontrolled did have problems. They did end up in the ICU. And again, in the pediatric population, uncontrolled asthma did lead to more serious outcomes from COVID-19. And remember, that you should continue all of your medications. Don't stop taking them, even when you feel good. That's key to asthma control. And just make sure you're checking in with your doctor and doing everything that you need to do. Next slide. And with that, I will, open it up for questions.
Okay, let me just tell both of you, we have a few questions from the audience, and let me ask the audience to please put your questions in the Q&A box at the bottom of your screen. Let me just open this up again. Let me tell you, one question is, what is severe asthma? And can you just talk about the difference between severe asthma and regular asthma, if there is such a thing as regular asthma? But I think just for everybody to understand why we think severe asthma is so much more important to focus on with the COVID-19 lessons learned and the impact.
So the way that we can I start? Do you want me to start?
Yes.
Purvi?
Go ahead.
Okay.
Yes.
So the way we categorize asthma really has to do with, number one, the frequency of the symptoms, right? So are there nighttime symptoms? Are there daytime symptoms? Is the patient awakening? Are they using their rescue inhalers? So increased use of rescue inhalers tells us. And depending on the frequency, and we have specific numbers that tell us whether it's mild, moderate, severe, that's how we're able to categorize. And as I always tell my patients, you may be a severe asthmatic who with very good use of medications and regular use can then not be a severe asthmatic. And I think that's important to remember, right? So the regular use of medications is what leads to control. When there's other forms of asthma. For example, there may be a patient who really doesn't have issues, except maybe when they're doing intense exercise. Well, we call those patients by a different name, that they're exercise induced, and they may only need to use a rescue inhaler before. So depending on, this is where it's important to seek medical care, so that number one, you know exactly what type of asthma. And again, I think going back to the triggers, knowing what your triggers are very important, because if you're able to address those, that is in fact very, very helpful. Okay.
Let me ask Dr. Parikh, the importance of medications has been talked about. We're here to learn and to share with Congress staff and others that are national advocates in our audience about types of policies beyond medication. One of the policies someone was interested in knowing about was, mindfulness and meditation and breathing techniques. What do you think about those types of aids for helping the persons with severe asthma?
Yeah, that's actually a great question that I get quite often. So the mindfulness techniques like breathing, meditation, yoga are a great addition to your controller medication. So they're not meant to replace controller medications, especially if you're someone who has moderate, severe, or any type of daily persistent asthma. Because remember, asthma is a disease of inflammation and mucus, as Dr. Trujillo said. So you do need your medications to keep that inflammation down. But where mindfulness and meditation and yoga and all of those things help is in decreasing stress. So we know stress can exacerbate any medical condition, any chronic medical condition, whether it's heart disease, asthma, obesity, diabetes, you name it. Stress is an inflammatory state on your body. So what those techniques do is they help you reduce stress, and then that can help your asthma control. But again, I just want to stress that it's not meant to replace what your doctor prescribes. The two together, though, work beautifully, synergistically.
Yeah, and do either of you have information that you pass out to patients that about asthma and also about COVID to help educate, but in Spanish?
I want to say, and I didn't say this before, sorry, Purvi,
No, go ahead.
we both actually partnered with Allergy and Asthma Network. They received a Eugene Washington grant, a PCORI grant, and Dr. Rios, you as well.
Yes.
We were able to take part on a 6-part webinar series. And I really believe that that was very valuable, not only for us as healthcare providers, right, but also as just to gain an understanding. There is really a need for education at every level, whether it's what is asthma, what is available. There were misconceptions about COVID. It was really just a very helpful and I know that they're still available, and I'm sure that those handouts may be available as well. So I think there is where I would start.
Okay.
Dr. Parikh, I don't know if you have any other recommendations.
Yes, I was going to recommend the same exact thing. The Allergy Asthma Network, in addition to that 6-part series, actually does a great job of having a whole host of resources, which are free for patients and their families. They can actually just go straight to allergyasthmanetwork.org. And it's a whole host of resources. So I encourage everyone to take advantage of it.
Great. No, thank you both for that. So another couple questions, and again, thinking in terms of how we develop policies. When you think about policies for the Hispanic community to learn about more educational grants, let's say, why is it that Puerto Ricans have higher asthma rates that you both have mentioned? Do you think it's environment, or do you think it's culture, or do you think it's lack of access? What do you think would be important policies to develop for especially those in Puerto Rico, or let's say in high concentrated Puerto Rican cities like New York or Chicago?
I think it's all three. And I think, honestly, they all need to be addressed. One of the, I think the National Hispanic Medical Association is wonderful in talking about the All of Us research, right? So that's an opportunity for us, not only as researchers, but for a better understanding, right? So I really believe there's genetic differences. There's no question. And it's not, whether you're from Puerto Rico or you're from Cuba or from another country, we're all different, right? We're all a little bit different. So I think understanding those differences, I do think that there are environmental factors. The research that I talked about, there was a recent paper in the last 2 years that was excellent, talking about those early childhood infections that we know are important, placing children at risk, but we know that also has a big impact. And then there's other factors as well. I think there's just a need. So any policies or any opportunities for advocacy to really just better understand, how we're all different and what would be most effective, because at the end of the day, without good research, we're really not sure the best way to address this.
Okay. And let me ask Dr. Parikh, another question is about rural versus urban settings, in fact, but not so much the problems, but what are protective factors? What can we do? And again, trying to think of congressional policies that can be thought about.
Yeah, that's a great question. So, there's a lot about that centers around something called the hygiene hypothesis, where we've found that certain areas of the country and the world that have more industrialization actually have higher rates of asthma and allergies. So believe it or not, being in a rural area, being in certain parts of the world where you have more access to microorganisms and quote unquote good bacteria actually helps develop your immune system in a protective way against not only allergies and asthma, but even autoimmune diseases and cancers. But we found that, that kind of concrete environment where, that access to soil and farm animals and those things aren't there, unfortunately, skews your immune system towards a more allergic phenotype. Now, rural areas, of course, have their own challenges with like access to healthcare, but in a way, they are protective against allergies, asthma, and other immune-mediated conditions. And it's interesting, and I'm sure all the doctors will agree. I have a lot of patients never had asthma or allergies, but until they immigrated to the U.S. and lived in New York or a city for 5, 6, 7 years, and then all of a sudden it developed. So it's very interesting phenomenon.
Oh, amazing. You guys are a wealth of information. I'm glad you're both here today. Let me ask another question about treatment. And this is because we heard you mention biologics. I mean, what is a biologic? And this is like new generation medications are very important for us to start understanding better. What is it?
So a biologic is an injectable medication that really targets different types of cells. And based on, we can do something as simple as a complete blood count, looking at the types of white blood cells, for example, looking at whether there's eosinophils or not. There's different types available. And I think that's just one example. There are right now several different possibilities. But I think, as I said before, having had asthma going back, and I remember as a kid being on very few oral medications and having side effects, and now seeing what's available, that's what gives me hope. And we need to share that hope with our communities because that is available. And we need to improve the access so that everyone is able to access those types of medications.
So as you're both doctors with patients with asthma, how would you tell policymakers to increase access? Is it just about cost? What else can we do? Cost, of course, we want affordable medications, but what are policy recommendations for increasing access to treatments and also the mental health side of asthma?
The biggest policy recommendation I would make is that access has to be increased by placing accountability on payers like insurance companies, even our government-funded insurance to cover these biologics, because Dr. Trujillo is right. They're a game changer, and they really help personalize it. Because remember, asthma is not a one-size-fits-all diagnosis, so not the same biologic works for every single patient either. And now we have a chance to tailor that care, get people off of steroids, oral steroid medications, get them out of the hospital, and prevent much more costs down the line. The issue now is access. So even patients that I have with very good insurance can't get them covered. So that would be, if I had to ask for one thing, is the biggest policy thing is just get coverage for all of these medications, because they can change someone's life and save someone's life.
Mm-hmm.
Dr. Rios, can I say something? Yeah, you mentioned the mental health component is extraordinarily important, and we don't consider, treatment of mental health probably in many of our patients with asthma, but the stressors that have been, discussed throughout this last hour are important, because any type of stress really makes an impact. And the last 2 years have been stressful for everyone. So sometimes it's not only having access to the medications, but it's having access to a psychologist or someone that the patient can talk about. Some people feel very distraught with this diagnosis and they don't have medications, and that puts them in an even worse position. So I feel that addressing both the mental health and that's something that policymakers can help with, right? Like those are policies that are necessary across the board, but in particular for our patients with chronic illness in general.
And I'm glad you mentioned that you mentioned about the importance of our community having better, relevant, culturally competent people to take care of them. And you both are examples of our doctors that have the experience with your patients, but mostly, more importantly, you have an understanding of your patients to be able to help them at whatever stage they are in asthma, whether they're the beginner or they're the severe asthma. So I want to thank you both for being with us today. We're at the end of the hour. I know that there's a couple of slides at the end. Vito, do you have the end slide here? So we have NHMA updates. First of all, I want to thank everyone for being with us today. I'm not sure what's going on here, but we have an end slide to invite you to come to other events that we are having over the next month or so. Let's see, I have okay, the biomarker testing event, August 25th, 12 to 1. And that is really about cancer, improving access to improved care. These are state policies that are being developed, and we would like, again, to educate people about the importance of how to improve health and decrease health disparities through these briefings that we're doing. We have a COVID-19 briefing on August 31st, and that one is in the evening, and that will be with Dr. Richard Carmona, one of our Surgeon Generals, and actually who's Puerto Rican from New York. We have our NHMA annual conference that will be in April in Chicago. And right now we have speaker abstracts and poster abstracts that are due the end of the month, next month, August 31st. And I'm also looking for sponsors, exhibitors, and ads. And we have our NHMA Vaccinate for All campaign with the new website at hispanichealth.info and vaccinateforall.org. We have many other programs, as was mentioned, the All of Us research program. And for more questions about our programs, Vincent Garrity at vgarrity@nhmamd.org can answer questions. And I also want to just say a big thank you to the Congressional Hispanic Caucus. And I know that several people asked us for the different bills that Congressman Ruiz mentioned. We will get that list to you, as well as and probably make a slide that we can add to his presentation on our website. So our website is nhmamd.org, and I would say next week sometime we will have this recording and our slides on our website, and also on our YouTube channel, the National Hispanic Medical Association. And let's see, I got another question here. Sorry. I'm looking at this. The Congress needs to make asthma care covered as preventive care. Yes.
Yes, that was my last point.
I can't agree with you more. You know, I have to say that when the Affordable Care Act came out, and we all know how important insurance coverage is, and we've talked about the importance of having better insurance coverage for our communities, but there was a whole section on public health and preventive care, and all of that is what has been slowly gone away, and we need to bring that back. And I think one of the biggest lessons with COVID-19 is that we need a stronger public health presence for public health grants and education campaigns, for example, especially like about asthma and other patients that have are vulnerable to COVID-19 and other respiratory viruses, that we get those public health programs up and running in our communities with all of our institutions in the community. But our people that don't have access to healthcare, you know, they're living and breathing in their communities, whether it's with the churches or with schools, with grocery stores, with the pharmacies. We need more campaigns to help our community organizations and institutions. And with that, I'm just going to say thank you all again. And we look forward to working with all the congressional offices that were on this call, and also with any of the national organizations. We welcome your ideas for policies to help our communities and to decrease health disparities, and in this case with severe asthma. So thank you very much. And I also want to thank our sponsors, especially Amgen and AMA and the Vaccinate for All campaign. Thank you very much.